This is a patient with known history of prostate cancer. So you can see this enhancing um, prostate mass here. And the staging CT abdomen pelvis. So it was negative, but there was something else here that I wanted to get your thoughts on. The mesentery.
Is that like
Yeah,
ectopic pancreas underneath the regular pancreas? Looks fluffy like pancreas.
yes, yes. So it's this thing here, right by the proximal jejunum, and it's fluffy, right? It's got the lobulations and the cleft, and then the pancreas is up here. So this is just, yeah, it looks like pancreas. So it's an ectopic pancreas, just
Yeah, and it
an
must be
ectopic
having some chronic pancreatitis probably because
like
the duct isn't
calcification. Oh,
normal. So it's got some calcs.
calcs, yeah. So
Cute.
All right. Okay, so this is a patient that has a history of colon cancer. And actually on this CT, you can still see the mass. They haven't been treated yet. And then they also have some lymph nodes that look suspicious here, and also some liver lesions. So you have these ominous looking liver lesions that on CT clearly look like mets. But we noticed that one of these lesions was associated with focal intrahepatic biliary ductal dilation. They happen to have a liver MRI as well. And focusing on that particular lesion, you see that indeed it is dilated intrahepatic bile duct. And the interesting part is, if you look carefully, there is this filling defect within the duct right here. I have multiple arrows showing that. So, metastases causing biliary ductal dilation, there aren't too many mets that cause that, that do that. Melanoma can do that, but we were curious to see if colorectal mets did that as well. And so we found this paper from AJR, which actually looked at a large cohort of patients. They looked at almost 2,000 patients. And in these patients, there were about 49 that had colorectal mets. And if you look at the distribution, they found about 16.5% incidence of patients that had colorectal mets had associated biliary ductal dilation. And then only about 3% of those that had mets from other primaries had biliary ductal dilation. So I thought this was interesting. And in this patient, it didn't matter much because we could see the mass and we knew that probably was the primary. But sometimes we encounter patients that have unknown primary, and if we see like a liver with the finding where there are mets causing intrahepatic biliary ductal dilation, then it might be useful to keep this differential in mind. So I thought that was interesting. And actually, I'm going to show you just in the coronal plane as well, just that dilated duct right there. So that was my first patient.
So takeaway is that most of the time they don't dilate the ducts, but they can. And so it's not like an abnormal feature.
Right.
Yeah.
That's true. And among the mets that can cause biliary ductal dilation, colorectal is one, by direct invasion of the bile duct. All right. This is a patient that, this patient has a history of lung cancer. And on CT itself, these are clearly adrenal adenomas. They look very low attenuation. Of course, this is not a non-con CT, but on the non-con CT as well, these were classic adrenal adenomas. And just to prove the point, I'm going to show you in and out of phase on an MR as well. So asymmetric, right larger than the left, and here is the out of phase. So very classic adrenal adenomas, right? This patient subsequently had a PET CT for staging for lung cancer. And on the staging CT, what was noticed was this left adrenal nodule did take up FDG, whereas the right did not. And then, adrenal adenomas can take up FDG, but what is said is that the SUV should be less than liver. A typical benign adrenal adenoma should not have FDG avidity more than the background liver. But in this case, even to the naked eye, subjectively as well, we can see that the FDG uptake seems higher than that of the liver. And so this kind of discrepant imaging findings with PET findings made them go ahead and biopsy this adrenal nodule. And the path report came back as an adrenal adenoma with lipofuscin within it. So I came across this interesting article and I thought this concept was interesting. So there is an entity called black adrenal adenoma, like the color black, and that's a histopathologic finding. So what it says basically is here, a black adrenal adenoma. So basically these are adenomas that have lipofuscin within them. And this article shows us the gross imaging or gross picture appearance of the adenoma. Here it is. So it looks black on gross morphology because of the presence of lipofuscin pigment within it. And these apparently can have FDG avidity, high FDG avidity, more than that of the liver. They still are benign, they still are adenomas. And I couldn't gauge from this article why presence of that black pigment causes increased uptake of FDG, but this is one variant of adenomas that can mimic a metastasis, for example, and throw us off, even though this is a benign entity. So just thought that was interesting as well.
I was not understanding what you said. So, but so I Googled it. So you're saying lipofuscin.
Yes.
And so what I Googled is that, what is lipofuscin? And it says it's an age pigment. It's a brown yellow autofluorescent material that accumulates progressively over time in lysosomes of post-mitotic cells, such as neurons and cardiac myocytes.
Right.
Exact mechanisms behind this accumulation is unclear, but super fascinating. I mean, if I had just seen that path, like the only thing I could think of is like a melanoma met, right? Because it's like dark and, but yeah, that's really, really cool. It seems like, I guess the question is, how rare are these? Because every time, like when something is FDG-avid, we're still going to try to say like concerning for met, right?
Yeah, exactly. And particularly because, so one thing is these are rare. So that's a good thing. I have to read the article in detail to see what is the actual incidence of these subtypes of adenomas, but nevertheless, they are rare enough. And also, given, suppose you see them in a similar context, lung cancer goes commonly to adrenals, and this kind of finding, no matter what, I think they would investigate these for metastases. If this was the only site, then, this would probably be biopsied before instituting therapy.
Very
so
cool.
It's interesting. Yeah, it doesn't change management by itself, but good to know that this entity exists, I guess.
Absolutely.
Right.
Okay, this was a 45-year-old patient, 2 weeks after hysterectomy, vaginal hysterectomy. Not for any malignancy or anything, just dysfunctional uterine bleeding and post-hysterectomy. And I'll show sagittal and coronal.
It looks like a fluid and air containing collection,
Okay.
but I almost wonder, is it a bag?
What bag?
I had a couple of cases of like retained surgical specimens where they like had put part of the specimen in a bag and then forgot to take the bag out of the abdomen.
Oh gosh, no.
Yeah, if it were a bag, what would it be containing?
Well, like a fibroid or part of the uterus. So the two that I had, one was a gallbladder and one was a rectum, actually. And what they did, like the rectum case, they had resected part of the rectum and then they went to do an ilioanal J pouch. So they tucked the specimen away because they didn't want to increase the incision and then like lose the pneumoperitoneum. So they tucked it
Got it.
away. They were going to go get it later and they forgot to get it. And it looked exactly like this, and that it was like this rounded thing with like air and fluid in it. So anyway, I'm going to
Right,
drop
right.
that.
No, you're on the right track. It's not so we called it an abscess, but then look at this.
Yeah, there's something like retained surgical. Oh, there's like a catheter in there.
Okay, good thought.
Too
So
big.
those were all things we thought of. Is it some kind of like not gossip eboma, but retained radiolucent suture material with a foreign body granuloma that got infected and things like
A
that.
bag.
A bag, as you rightly said. Then IR went in and drained, and they got 30 cc's of pus.
Ugh.
And the IR person also said when they stuck their needle in, they felt something along the walls of this collection. So, wildest guess, but I'll show you the intra-op picture. And because IR said they felt there was some foreign body, patient actually following the IR drainage got taken straight to the OR. So I'll show you the intra-op image. And I withheld a little history, which I'll show in a second, but that would have taken away the fun of the case. So, okay. Do you see my screen?
Yes.
Oh, wow.
Oh, is it a pessary? Oh no, a
it's-
glove?
No, it's a condom.
What?
So, yes. So I think at some point, maybe being post-op, she must have had very friable cuff at the top, right? So just 2 weeks after surgery, and later on in the history, she said, yes, there was attempted intercourse, and then patient felt severe discomfort after that. So I think there must have been a small perforation through the cuff, and the condom got retained in the pelvis. So I think in retrospect, the edges we were seeing, that radiolucent ring-like thing, may have been the edge of this thing. So your thought about a bag was kind of right.
I know, that's so
Wait,
weird.
wait. I need a question.
Yes.
This happened after hysterectomy?
Yes.
So wait, you need a condom once you have hysterectomy?
I was hoping somebody would ask that question sooner. Yes, we had a laugh about that
Well,
too.
yeah, for STDs.
Or yeah, maybe for
Okay,
infection.
all right, fine. I did not think this one through. Yes, you're right, for STDs for sure.
Yes,
I'm just thinking about pregnancy prevention.
I agree. I agree. We had a laugh about that too. But she was, in retrospect, she was being extra cautious that she didn't want to get infected because she had just had surgery. But this radiopaque rim, I guess, was the thickened outer rim of the.
What was it filled with? Jesus Christ. Okay,
It was pus,
let's not go there.
Victoria.
Let's not go there. Let's not go there. Oh my God.
Yeah, no, it was pus. They got 30 cc's of purulent stuff out.
So actually, in my case with the retained specimen in the bag, it was the same thing. We drained it, and then we were like, this is really weird. Why does it have like this shape to it and whatever? And then we went to look for the surgical specimen in the pathology report, and there was no surgical specimen. And that's when we put the pieces together that it was like, there's something called an RSS, retained surgical specimen, and it's a known complication of laparoscopic surgery. But yeah, anyway, this is an interesting correlate.
Yeah, I thought this was a glove, like a remnant of a glove. Also, when my resident showed me, I was like, is this a glove that tore off and accidentally got
Wow.
left in? But it was more interesting than that. So yeah, reminder to look for these small foreign bodies. And I guess it's latex or rubber, so it's not going to be as radio dense as some of the other suture material that we expect.
Patient came to us with a diagnosis of, incidental revolution, no prior studies, we have nothing. So, you can see here's segment 2, there's no fat. There's kind of intermediate, right? Sort of looks like evil gray of tumor. Maybe there's a central scar. There's diffusion restriction. And here's the pre and post contrast. So this is pre, it's the arterial phase, kind of hypo-enhancing, and then sort of kind of areas of central enhancement. So any thoughts or?
Any old scans that show like a hemangioma that used to be there?
So we had nothing, no prior studies, nothing. So this is,
Otherwise, it's like this is a surgical case or whatever biopsy case until.
right. So this is exactly what we said. We don't know exactly what it is. If I recall correctly, the read was, probably malignant. And with this pattern of enhancement, kind of we're considering mostly, what do you call it?
Cholangio.
Cholangio, and sent her biopsy, and the biopsy came back sclerosing hemangioma. So nice and easy case.
Can you show the T2 again? Anything we can glean from this?
Oh, really? It actually pretty kind of ugly. Maybe the scar centrally, but that's neither here nor there.
Sorry, what was the diagnosis again?
Sclerosing hemangioma.
Okay.
So, like in retrospect, we can say, okay, all these kind of weird areas of enhancement probably just, but, with sclerosing hemangiomas, they can really mimic malignancy. I have cases that just really look like intrahepatic, like really perfect intrahepatic cholangio. And then ended up being, and then,
This is why we all need full body pre-novo MRIs as baseline so that when our hemangiomas sclerose down, we have the prior. The one thing I'm seeing is like, do you see how it's sort of like hanging off the liver? Like you could almost imagine that it was something bigger that then like got smaller, but
I don't know. That probably is, to me, is not a great sign, because I've seen, cholangios hanging off right like that. So I think without prior studies, the only thing I suppose, like, I guess getting PETs would help, right? Because with a lesion of this size, if it's if it's PET negative, it's an FDG negative, I imagine it would be reassuring. But honestly, like, I can't imagine under what circumstances without prior study I would say, you know what, it's okay, you don't have to biopsy. Unless
Victoria, do tagged RBC cells help at all in this?
Say it again. I don't
Do the
think
nuclear medicine tagged RBC studies help? I don't know if there's sclerosis, how much they might take up, but
I don't think so, right? Because the contrast distribution is what you would expect with RBC scan, right? So
yeah, I'll tell you the converse too, though. I've wrongly called these sclerosing and they've ended up being cholangios also, similar looking like this in the left lobe. And in retrospect, like at that time, we attributed the capsular retraction to the sclerosis, but it was truly more of, and that one had to get biopsy 2 or 3 times before they could, it was a small lesion. Hence the struggle was larger, but these are tough, like you said, I think.
so just a quick companion case. Here is a MR, T2. We've got this lesion here. It's got bright spaces as well as dark spaces. This is what it looked like on pre. It's just kind of maybe a little bit of T1 hyperintensity, arterial, and delayed. So a lot of progressive enhancement with non-enhancing kind of central areas. I think for me, the key is really T2 bright areas and then some T2 dark areas, I guess, but, and then capsular retraction. So this is a companion case. This was a sclerosed hemangioma, biopsy proven. And I guess the point I wanted to bring up is there's two things, sclerosed and sclerosing. So this one I think is sclerosing, like it's still on its way, but it still has fluid-filled components to it. So it's not completely fibrotic, not completely mimicking a cholangio like evil gray. And then the second point is I think that sclerosing hemangiomas are actually more common than we think. So we've shown so many at this conference. But if you look in the literature, they'll be like, this is really rare, diagnosis of exclusion. So I'm starting to think that they're a little bit less rare than we think. And maybe just because hemangiomas are also really common and we have like an aging population. So over time, they will, a percentage of them will involute down. So anyway.
I want to share my companion case too.
Okay, hold on, let me stop.
I presented this a couple of weeks ago, but I think as I see 3 consecutive cases, you're like, oh, they look similar.
Okay, hold on.
So this is a companion case to the two that was just and as I look at the two cases, what I like notice is these little like cavities, these cystic cavities, right, in the sclerosed hemangiomas.
Yeah, and
So
this is a really nice one where you have really T2 bright and T2 dark, right? And so like what tumor usually does that? You know, we think about cystic tumors like MCN, but this looks really weird for an MCN. So, and this one was biopsied, right, Nelly?
no, we got the prior.
Oh, right. Yeah.
And then the priors, this will look like. This was from 10 years ago or something like that.
So this is
10
the
years
case for
prior.
having a baseline.
Yeah.
Cool.
So 30-something-year-old patient comes in with right upper quadrant pain. He is jaundiced. So we started with an ultrasound. And I'm only sharing part of the screen here because I don't want to show PHI. But anyway, this is the Doppler image of the same thing. So any thoughts on what we would call the gallbladder at this point?
Abnormal.
Okay.
Yeah, I
And
mean,
I'll show
there's
you
no
this.
normal gallbladder, right? It's like this thickened, maybe
Right.
decompressed. There's some kind of
Yeah.
like diffuse thickening there.
Correct. Correct, Nelly. So this is the lumen with a little
Not
bit of.
cholecystitis. Yeah.
Yes, so lots of kind of concentric circumferential wall thickening, not a whole lot of hyperemia. The adjacent liver didn't show any hypoechoic fluid collections. Here was
You
the
can
C.
get like diffuse adenomyomatosis.
Okay,
Oh, wait, but here it
here's
looks
the
just like
CT.
really edematous.
Some periportal edema in the liver. Then we got a little concerned because we saw all these nodes and what looked like a little bit of stranding around the duodenum. We really weren't sure.
Can you show the
So,
coronal?
yes.
What's happening at the pancreatic head? There's like so much fullness there, but maybe it's just I don't know, there's something happening.
So I'll show you the MR. So we were
Lots of
not sure.
nodes.
We mentioned all these findings and then we got an MR. So now what do we think of the gallbladder? And we didn't have any post-contrast images. I can show you diffusion if that helps. I think this is highest B value. So going back to
The patient
T2.
hasn't had like gallbladder surgery, right?
No, he still has a gallbladder. His LFTs are very deranged though.
The mucosa looks abnormal to me, like disrupted.
Right, that's
Like,
kind
is
of what
this
we were worried too.
gangrenous?
So that's exactly what we were worried about too. But the ultrasound and the MR were within a few hours of each other, Aarti. So we kind of raised the same suspicion. The wall looks irregular. There's too many lymph nodes. There's too much stranding. Is this some sort of acalculous coli even? But patient was not that sick. He just had elevated LFTs, right upper quadrant pain and fullness. Then he got treated for, so surgery saw him and deemed him not to be a surgical candidate, or they were not concerned about acute coli. Looking at his LFT pattern, they were actually more worried about him having hepatitis. So they decided to medically treat him. So, and I'll show you the follow-up here. So this is 2 weeks later. Now look at the gallbladder. So nothing was done. So he was just medically treated for the hepatitis. So I guess in retrospect, this is just a severe case of gallbladder wall edema and that crumpled mucosa-like appearance from adjacent hepatitis. The periportal edema had resolved at this time. The nodes were gone. All that periduodenal inflammatory stranding was gone. So interesting to see how based on MR and ultrasound, it looked very concerning to us, at least on that first scan. And then things just spontaneously got better for him.
That's great. Do you know what kind of hepatitis it was? Like, was it?
B. It was B, acute B.
Oh, wow.
Yeah. So I
Cool.
guess it's a reminder that gallbladder wall thickening can look nodular, irregular, can have associated lymphadenopathy in the setting of adjacent severe liver disease. So puzzling case, but glad for the patient.
Great case. This is a patient with prior episode of diverticulitis. So here it is here. And then patient came in with abdominal pain like 2 years later. So then this was a 2-year study prior, and then this is the study that was done 2 years later for abdominal pain. They're looking for diverticulitis. So there's no diverticulitis, but there's something else that's new.
All the small bowel loops look thickened,
There's like a fluid collection.
matted, yeah,
Very.
mesenteric collection,
What do you think it is?
or some kind of necrotic tumor hanging off of the small bowel.
And then here's an MR.
Some gist-like tumor, Nelly.
Okay.
Shape is really weird.
Yeah.
But did they have surgery for their diverticulitis, or would
No
they just
surgery.
treat it medically? Okay. I'm thinking it's some kind of abscess.
Yeah, it's very tethered and lobulated.
Maybe
Um,
like a perforation of
No
small.
Crohn's or anything, right, Nelly?
The patient had a history of yeah, it's not Crohn's, just diverticulitis, reflux. Yeah. And there's another history, heart transplant.
Makes me
So
think of
10 years
immunosuppressed.
prior.
PTLD or something, but
Yeah.
So this was biopsied because that was a differential. Like it could be malignancy, but it could be kind of infection, a typical infection. And this was mycobacteria.
Oh, where are the low
Acid
density
fast.
lymph nodes?
What?
No low density lymph nodes typically, right?
or is that whole thing like a big look?
Oh, like a nodal
That-
conglomerate.
Yes, yeah, the whole thing.
Oh, nice, nice. Oh, that's large for a nodal conglomerate.
So Nelly, did they have TB previously, and this was like reactivation with immunosuppression?
Oh, that's a good question. Let me look it up and then I'll get back to you. I don't know.
Okay, so this is a pregnant patient. We can see uterus. And do you guys see anything else?
Yeah, there's like placental invasion.
Yeah,
Previa.
with like
and-
marked thinning of the myometrium here. We didn't see any
Yeah.
definite invasion of the wall or the bladder, but
Yeah,
looks
the
like
bladder looks intact, yeah.
yeah, placental abnormality invading at least the myometrium, lots of thinning here. So we thought about that. The patient was also unstable, and I'm just going to show you. There's some fluid down here that was actually hemoperitoneum, which you can see some of the layering fluid hematocrit level here. And they had, this is post-paracentesis where they already removed 600 cc's of blood. So they ended up going to the OR, and this was placenta increta. So it was invading into the myometrium with also rupture, uterine rupture, where the placenta was like bulging out of the lower uterine segment and like bleeding into the pelvis. So this patient had had multiple prior C-sections. That's the main risk factor for patients with placenta accreta. Often the invasion is at that level, like near the C-section or anteriorly here. And if you have hemoperitoneum, also have a, higher suspicion that things are penetrating all the way through. They called it rupture, but basically, yeah, the myometrium had ruptured and the placenta was just like coming out. So this is a testicular ultrasound, and we're focusing on the epididymal body here.
What are those little bubbles?
Yeah,
Like
what are the
air.
bubbles?
Are they, is that air? What is that?
Dancing sperms.
Uh-huh. Do you know what this is called?
There's some sign to it, right? It's like this. I'm forgetting what exactly, but there's some name to it.
Yep. It's called dancing megasperm. So here it is in Radiopedia, dancing megasperm, which is oscillating tiny echogenic foci within dilated tubules of the epididymis, seen in post-vasectomy patients with obstruction of the spermatic cord, and it's thought to represent clumps or clusters of trapped sperm. And they only oscillate or dance when you do ultrasound on them. So like, because of the ultrasound waves, they sort of, the clumps will start moving around.
That's cool.
Yeah, we actually had 2 in one day. So we were like, wait, is this like a new thing? Our ultrasound machine is like so sensitive, but turns out it's usually seen in post-vasectomy patients. So this is a rug, and I've had a string of rugs lately where people have had bulbar strictures, a lot from STDs actually. So STDs are apparently back on the rise, kind of related to Roopa's case, so we need to be careful. But anyway, this is a rug. So we're injecting, this is the penile urethra, and then we can see that there is this stricture of the bulbar urethra here with dilation of the proximal bulbar urethra proximal to the stricture. And then we do get some contrast going up into the bladder. So aside from this area, this is what the normal membranous and prostatic urethra look like, and like the little wisps that you'll see in the bladder. And you want to try to elongate it. So you can see that in this position, this is not elongated, but back here, we sort of saw like the full length of the stricture. And then you're going to want, at least on our PAC system, we have to calibrate it against some other bony structures so that we can measure the length of it. But if it's over 2 centimeters, they often need to do surgery with buccal mucosa and do a graft. Laser dilation often does not work, especially for these longer strictures. And even for shorter strictures, laser dilation, I think, has like a 30% success rate, but often they'll try it once or twice. And then if it fails, then they'll go towards a graft. So just an example of a rug.